Chivates sir is the founder president of our society, and he made this society, and it is his dream that a painless hemorrhoid surgery or painless anorectal surgery should be done. And his second aim was it should be percolated up to the periphery of India. And that's why this ISCP was formed, and this ISCP is doing most of the workshop and courses in Tier 2, Tier 3 city as well as in bigger cities also, so that it should be percolated. And here it is this society only where all the beginners and younger budding surgeons also getting chance to present, speak out. And because of this, we can discuss to and fro from your side and from my side and discuss all the problems. And the basics will be discussed in this, and so that we all go home with some good learning, and we should start this practice. The Chivates sir is known for his lateral thinking. Do you know what is this Chivates technique? What he has done? Pointer. This is the commonest diagram which we see. Mostly the surgery are done at this level, Milligan-Morgan at this level, laser at this level, MIPH slightly higher up. What Chivates sir has decided, because there are two components in hemorrhoid, one is the prolapse, second is the bleeding. Prolapse is coming from higher up. So what he had done, he has applied the suture at the level of, this is the dentate line, he applied the suture at the level of 2 centimeter and applied the suture at the level of 4 centimeter. He blocked the vessel. Because of the blocking of vessel, the circulation stopped. The second, he applied the suture at the level of submucosa, so the prolapse part is again reduced. So these are the two most important components of hemorrhoid, and this dealt with only Chivates procedure, not with any other technique. Milligan-Morgan, the cushion is disturbed, so 20% chances of recurrence, incontinence is there. MIPH, only one row is there, so the chances of collateral formation and recurrence is there. In laser, they deal with the bleeding but not dealing with the prolapse part, and so the chances of recurrence is there. This is the only technique where he defined that if you apply the suture at 2 level, the chances of bleeding will stop, the chances of prolapse will stop, and chances of recurrence will not be there. So this is his thinking. This is because of his lateral thinking only, the suture mucorectopexy and the sacropexy for the prolapse of the rectal prolapse has come up. And there are so many innovations which sir has done. I am not going in detail. Now the next. So what is the hemorrhoid? It is the vascular mass of arteries and veins that is called corpora cavernosa recti, which prolapse due to the legs connective tissue. And what are the causes of recurrence? Because of the formation of collateral, increased anal tone, and repetitive history of constipation which lead to prolapse. So what in Chivates procedure, the principle what we are doing is the reduction of pile mass, second blocking the vessel at 2 level, third creation of bare area in between the two so that the collateral will not be formed, and third is the fixation of the pile mass. What are the indication? Basically it is indicated all the grades of piles. Grade 1 is conservatively, so no, but grade 2, 3, 4, single or multiple piles, circumferential piles, anywhere we use this Chivates technique. Because of any other technique, if there is bleeding, you can go for this Chivates technique to tie the suture. As a part of Chivates sacrorectopexy, we use this Chivates technique. Mucosal prolapse of rectum, we use this technique. And control of bleeding because of any other cause, because of foreign body or any other trauma, we use this technique. Contraindication, as such, there is no absolute contraindication, but android pelvis, we have to, because we are not able to dilate the anal, so we avoid this Chivates technique. We can use for any other technique. Instrumentation and gadget, this is the most cheapest procedure, most cheapest technique available for hemorrhoid, can be practiced in government as well as private sector, because here only Chivates proctoscope that cost around 6,000 to 8,000 rupees, and second is the suture material, that is Vicryl 20. Other is the long needle holder, long forceps and suction cannula. So this is the Chivates proctoscope. It is outer diameter is 4 centimeter. Why? The maximum stretchable diameter is 4 centimeter. That's why it is 4 centimeter. Inner diameter is 3.8 centimeter. It is transparent. It has a marking. So because of the marking, we are able to identify the dentate line. We are able to identify the 2 centimeter and 4 centimeter dentate line. This is the suture material. This is 100 centimeter. Normally the suture material available is 70 or 90 centimeter. This is special material 100 centimeter, so that circumferential double purse string suture can be applied with the single throw. It is 5/8 circle needle, and the special designed suture material with the name of LDL for the Ladukar sir, because sir has defined and sir has suggested to the Suture India, and they prepared this special suture material. Now the reduction of pile mass, now per se the technique, the most important, first I will show the technique. This is the, I borrowed from Ladukar sir because he is practicing purely the Chivates technique. I have done modification, now I am doing only modified. So what is the important step is, you pass dilatation. First important step is the dilatation with the help of 2 finger, then 4 finger, so that our anoscope or proctoscope can easily be introduced. What the technique is, you start at 3 o'clock, take a bite at 3 o'clock, suture it, then take continuous second bite. Second bite you are taking, now if you are seeing, he is taking the double throw, double knotting at each level. So individually the stitch is locking at each level. At present sir is taking at 4 centimeter above the dentate line. In another video also we will, I have 2 or 3 videos to show, so that you will learn the technique, and tomorrow we have 2 operative also, so that you should, everyone should learn this technique. This is the most simplest technique. Circumferentially you have to take it, 2 throw, 2 bite. Each stitch should not be more than 1 centimeter. Anteriorly when you are taking, in female you should take care of vagina, because if the throw is deeper, the chances of vagina can be included and the complication will be there. In male the prostate is there, so the chances of pain and chances of bleeding will be there in male also. So anteriorly you should be bit precautious. Few questions come in mind, why 2 centimeter and 4 centimeter, why not 5 centimeter, why not 6 centimeter? Because up to 4 centimeter it is retroperitoneal, Donen-Weller fascia is there at 4 centimeter. So the chances of injury to the other visceral organ will be avoided if you take a deep bite. As such the needle is 5/8 of the circle, so it avoids. Now this is the first ring. Now the second ring is taking. This is dentate. Second ring is 2 centimeter. Chivates sir used to take first 2 centimeter, then 4 centimeter. Now what we are taking is first 4 centimeter circumferential stitch, and then 2 centimeter. Because of the first 4 centimeter, we are able to control the vascular pedicle proximally. So the second layer where our stitches mostly come through the pile mass, through the vessel, the chances of bleeding will be less. Same circumferential stitch. So how this, why we apply the suture at 2 level? The advantage is, once we apply the suture at 2 level, there will be a bare area, so the chances of collateral will be reduced. And if this bare area is there, then why not the gangrene or necrosis of the mucosa in between? Because of the transmural blood supply will be there in the mucosa, so the chances of necrosis or a gangrenous changes will not be there, as per the McGregor surgical anatomy book. This is the principle. If you apply the suture at 2 level, the chances of collateral will be less, because there is a vessel at blockage at 2 level. This is against the MIPH, where the 2 end comes proximal, so chances of recurrence will be there in MIPH. This is the condon view. If you see, this is the dentate line, this is the first suture, this is second suture, and this is anorectal ring. Same, what we apply the suture. Again, now the picture you will understand what we are doing. So the usual complication of hemorrhoidectomy, like urinary retention, severe rectal bleeding, anal stenosis, constipation, iatrogenic injury like perforation, they doesn't encounter in this procedure. Double locking of the suture is done in this technique, and so individually the vessel is ligated. The depth of suture, if you take, it will be mucosa, then submucosa, then part of muscularis mucosa will be there. All the vessels are come across and they are tied. So these are the study from the Ladukar Sir Center. 1800 cases in 14 years he have done, and these are the studies, and the results are mostly because with this expert hand, the chances of prolapse is only 10, pain is usually minimal. A small learning curve is there in this technique, but not very much. All we are general surgeons, so we can always practice this technique. Only 1 or 2 cases can be done. 1 or 2 cases we will expertise in this technique. These are the few pre-operative and post-operative pictures. In circumferential pile, multiple piles, whenever initially when I used to go for Milligan-Morgan, but now why I have changed to this Chivates? Because in Milligan-Morgan, if you apply, the chances of stenosis will be there, chances of pain will be there. But now because of the good painkiller, it can be controlled in Milligan-Morgan also. But the only problem is in the circumferential piles, it is very difficult. In Chivates also, if there is prolapse of mucosa, if there is single bigger piles, we can excise that piles. We can excise the skin tag. So, conclusion is, it has less pain, less hospitalization, no recurrence, least complication, very affordable to the patient. So, what I say, gold standard is yet to come. Few of the complications what we come across is the pain at the suture line, which can be reduced with analgesic. Second, if the preparation is not good, chances of fecal infection will be there, which may need enema. Minor bleeding may be there for first 7 days. External tag, if there, can be excised. Core factors are the hemorrhoidal mass, which we deal with the 1 centimeter double stitch. Prolapse grade 2, grade 3, grade 4, circumferential suturing we are taking at 2 level. Why we are able to avoid the recurrence? Because of the 2 row of stitches. And why we are avoiding the pain? Because it is above the dentate line. So the same tips and tricks. The most important is stiff head loop position. Second is the anal massage. Third is the reduction of pile mass. Fourth, stitch should not be more than 1 centimeter long and should not be more than deeper than 5 millimeter. Thread should be pulled and a tent to fix up with the rectum, and needle should be strongly held and is rotated. Tomorrow we will show how the needle should be rotated, so the chances of injury or bleeding will be avoided once it properly needle will be taken out. There are various publications. The first publication in 2012, now more than 20 or 30 publications are there for this technique. Thank you. Should I go to my next talk? Last month only I had gone to Everest Base Camp. So this is the photo from there. Yes. Now, why this is the best technique, everything is there. Why I have come up with the modification, this is the way. And now almost all our surgeons are practicing, all our senior faculties are practicing this modification only. The advantage of Chivates we have seen, bleeding stop immediately, there is no wound, no dressing, patient discharged 24 hours, cost effective, no costly instrument, non-excisional, so it is very good procedure. But only shortcoming which I have observed in my more than 400 or 500 cases in my beginning in last 4-5 years, patient always have a feeling of hard, held up of stool. Because the stitches are there, so the patient always has something is there, मुझे कुछ तो गड़ रहा है. कुछ तो भी अटके जैसा लग रहा है. That was the feeling of the patient, and mostly it usually there for first 2 to 3 weeks, because after 3 weeks the vicryl dissolves, so this feeling goes. But for first 3 days sometime or first 3 weeks, most of the patient come to you, sir कुछ तो भी heaviness लग रहा है, motion नहीं हो रहा है, 10 times जा रहा हूँ but निकल नहीं रहा है. So this was the routine feeling. Perianal discomfort may be there because we are dealing with the vessel, but nerves are again coming up. So there is nerve entrapment. Mucosal edema, because circumferentially we are applying the double suture, so edema is there. That may be the cause of this stitches we apply. So this is the fecal matter. When you see, when it comes to the lower rectum, the rectum stretches. Anal canal has a capacity of up to 4 centimeter, but rectum has a capacity up to 8 centimeter. So actually, when we apply at 4 centimeter stitch, it is at the lower rectum. So because the lower rectum is not completely distended, so because of this, the patient has this feeling. That's what I am thinking. But again, technically, one more literature has come up.
Receptors
Volume.
stimulated by the filling of the
Volume,
rectum
volume.
activate the defecation reflex.
Actually,
It's an
the
autonomic nervous
defecation,
system reflex in which sensory
defecation is the
impulses
process where
are
both
sent to the
parasympathetic
control
and
center
sympathetic nerve
in the
works.
spinal cord. As parasympathetic impulses travel down the spinal sacral nerves, they stimulate longitudinal contractions of the rectum, forcing feces into the anal canal. They also relax the internal anal sphincter, allowing the feces to move toward the external anal sphincter. The voluntary relaxation of the external anal sphincter allows defecation to be completed.
So this is the process of defecation where stretching is very important part. So if you are disturbing the stretching at the lower rectum, so this will indirect pain and a feeling of held up will be there to the patient. That's what I want to say. So the same video.
Stretch.
So to reduce this problem, I have come up with my own personal modification. That is very simple modification. I doesn't want to take any credit from Chivates sir because he is God, he is our Dada. And this is just a small modification which I had taken. So where various steps of this, one is the patient position. Stiff head-low position, 30-degree head-low position should be there. The aim is to reduce the pile mass. This is the first step of our Chivates technique. Stiff head-low position. Next step is dilatation. 4-finger dilatation or up to 4 centimeter dilatation. Why it is important? Because our proctoscope, anoscope is 4 centimeter. It has a inner diameter of 3.8 and outer diameter is 4 centimeter. I am repeating the same step because you people has not seen what is Chivates and at least you should learn something. And this is very simple procedure, everyone can do it. So, instrument is the Chivates proctoscope and the Vicryl 20 suture. Now, what modification I have done, just I want to explain. Because we are applying the circumferential stitches, so the stretchability will be disturbed. So, what I start at one end at 3 o'clock and discontinue at 9 o'clock. And again take the stitch at 9 o'clock and discontinue at 3 o'clock. So, the rectum becomes the 2 half. So, the dilatation will be maintained. At the same time, we are blocking the vessel. So, these stretching receptors are not stimulated, though chances of incompleteness feeling will be avoided with this. This is the just a small modification. Otherwise, these things are same. We start at 3 o'clock, applying the double interlocking suture, continue up to the 9 o'clock, and then again we apply a knot here, discontinue, again we take another stitch and continue to the other end. This is the dichromatic picture. Now this is the operative technique. Same proctoscope, same everything. Here we can easily see, this is the newer proctoscope which the Chivates sir has made. This is the dentate line. I am starting at 4 centimeter. You have the dentate line, you have the first stitch at 4 centimeter. So it is very easy to identify the 2 centimeter level. Next important step is people used to come down in second level so that the pile mass will be reduced. But what I have seen is the edema is there. So here I am discontinuing the stitch. Now again I just a bite lower so that the vascular obliteration will be there. Mucosa has a quality of stretching, so there is no problem. Now again I am starting, and same from 9 o'clock I continue the circumferential stitch. Same circumferential, again reach to my 3 o'clock position. So this completes my first row. Now second row, easily identifiable, this is dentate line, 4 centimeter, so at 2 centimeter I have started. On first case you may take 1 hour, 30 minutes, but once you well versed with the technique, it will take not more than 30 minutes, not more than 20 minutes. On table only we can get the reduction up to 80%. And because of the postoperative edema and all, after the 2 weeks we are able to see. Few of the, again we have seen, because we have dilated the anal and we keep the proctoscope for longer period of time, for up to 1 hour or half an hour. So the patient postoperative have a laxity of the anal tone is lax. So it comes to normal in next 7 days. Few of the things what again I have seen is, you give the laxative for first few days, later on the bulk laxative is needed basically, because the laxity of the anal tone is there. So bulk laxative is much better, works in this patient. But initially we have to give the irritant laxative like cremafin. So this completes my 2 row. If you see circumferentially, these 2 row you can see all the side. Okay. So the advantage, no feeling of held up stool, no feeling of incomplete evacuation of motion, thereby normalizing the frequency of motion, perianal discomfort or edema is reduced. These are few of my cases in last 2 years. I am doing more than 170 cases I have done, and with this pain and all are very less. So modified Chivates technique, that is Vikas modification, has come up with promising result at par with the original technique, and also rectifies the shortcoming of Chivates technique with lesser and lesser complication. So my word for Chivates, you have planted the seed of knowledge in our heart. We pledge to nurture them into a long-lasting legacy. Thank you, sir. Yes, sir.
Sir, this is 2 and 4 centimeters.
Yeah.
Why shouldn't it be 1 and 3?
Sir, that's what I have told. Upper limit 4 is fixed because above that peritoneum, intraperitoneal structures can come. If you come below 2 centimeter, sometimes bigger piles, when the circumferential grade 4 piles, prolapse piles are there, we try to go towards nearer. You can go up to 1 centimeter, but not before, because of the stretching. It will pull the dentate line, so the patient will have pain. Second, once you come more nearer, the chances of edema will be there, postoperative edema will be there, and patient always have a feeling of discomfort. That's what. Yes.
Not disturb the transitional zone, because it ultimately samples that. So it's better not to.
Third, if there are prolapse mass or if the prolapse tag is there, you can excise. I have told, if there is one bigger piles is there, don't hesitate. We have to give the best result to our patient. If you are seeing after the completion of procedure, this is the bigger pile mass, this will not able to, we are not able to get the result, and patient may come up after 2 months with that mass. So you can excise at that time, because already we have controlled the vessel, so there will be no bleeding, or there will be very less bleeding. Or only one thing you are excising, so postoperative the pain control will be better as compared to our standard Milligan-Morgan. I think all the fellows have more and more question, and you can ask tomorrow also during the operative.
Okay, last question.
Yes, sir.
4 centimeters from the anal verge or dentate line? Or
From the dentate line, sir.
from the dentate line?
Yes, sir.
Thank you.
Thank you.
Now
Yes,
request
sir. Yes,
Dr.
sir. Nothing happens, sir. Most of the time, when the second row at 2 centimeter we take through the pile mass. So vessel always come across. Nothing happens. Once you double locking it, it will stop the bleed.
Sir, this is a truly make in India technique, and I have brought my own designed mannequin today evening. You can have hands on that mannequins with actual Chivates proctoscope and that proper suture material 5/8 of circle. I have got that mannequin with me. I request Dr. Harish to give me some space to keep that mannequin where we can teach the fellows. Thank you.
One point I want to highlight is that this technique, like the purse string Dr. Vikas is taking, in this we take some fibers of the internal sphincter also, unlike what we do in the MIPH. So this is little different from the MIPH. The bites are little more deeper, and it should include some parts of the internal sphincter.
Sir, not internal sphincter, part of muscularis. Internal sphincter is actually the continuation of muscularis mucosa.
Yeah.
So you are taking the muscularis, not the sphincter.
It's part of that only.
Yeah. Sphincter after the dentate line comes.
It's continuation. It's continuation of that part only. Yes.
Thank you, sir, for the insightful discussion on the topic. Now we request Dr. Hari, sir, to present the memento to Dr. Vikas Jain, sir.